How is it that children suffering from one of the world's most deadly infectious diseases continue to be excluded from medical progress? Every year, 1.25 million children and adolescents contract tuberculosis, or TB, but only half are diagnosed and treated. 9 out of 10 who die from the disease have never been treated. The main cause is the difficulty of making a correct diagnosis in children. Current TB tests are designed for adults and are not sensitive enough for younger children. Another difficulty is that symptoms among children are very different from those of adults. For example, in children under 5, there is not necessarily a chronic cough, and extrapulmonary forms of TB are more frequent. Finally, children are less likely to transmit the disease and are not considered a priority for controlling this infectious disease. Even when children are close contacts of people who have TB, they do not systematically receive preventive treatment. The public health approach, therefore, focuses on adults, as they are the main transmitters of the disease. On top of these obstacles, there is also a lack of human resources to screen and diagnose TB in many primary healthcare facilities, as well as a lack of access to diagnostic tools such as X-rays and laboratory tests, particularly in low and middle-income countries. These challenges make it hard to detect TB in children, which delays treatment and puts their lives at risk. In countries with limited resources, such as Afghanistan, Central African Republic, Niger, South Sudan, and Pakistan, MSF teams often find that children are treated for malnutrition while TB remains undetected. Tuberculosis is a serious comorbidity in malnourished children that increases the risk of death as it weakens the immune system. As well as essential to treat undernutrition, which is common in children affected by TB, food and nutritional support are key treatment enablers, helping to improve their health status and influence adherence to treatment. But nutrition alone is not enough to keep them alive. To combat pediatric TB, in 2022, the World Health Organization published several key recommendations for children and adolescents. First, the use of decision algorithms to help diagnose TB in children based on their symptoms and in the absence of laboratory results. The system is based on points awarded to the child's symptoms and history, and is thus a patient-centered approach. In addition, the WHO recommends the use of short oral treatment regimens to treat and prevent non-severe forms of TB in children. In Somalia and in Niger, amongst other countries, the WHO recommendations have been implemented by MSF teams. The result, many more TB-positive children detected and treated, fewer misdiagnoses, and fewer TB-related deaths. On average, in the countries where we work and where these recommendations are implemented, the number of children diagnosed and treated for TB is up to 5 times higher. However, national public health policies in many countries having a high burden of TB are not aligned with those WHO recommendations, as that requires resources to change their policies and to implement. A report published in 2024 by MSF about 14 countries with a high prevalence of the disease reveals that only 1 country has a national policy for the diagnosis, treatment, and prevention of TB in children that is fully aligned with the WHO. Change also involves new, shorter, all-oral treatment regimens for children. Although available, new anti-tuberculosis treatments adapted to children are not always taken up by countries due to bureaucratic obstacles and funding shortfalls. As a result, many children suffering from non-severe TB are forced to take treatment for longer than is needed. In addition, although child-friendly formulations of TB drugs exist, they are not always available to children, forcing them to swallow crushed, bitter adult pills in doses that are not adapted to their weight, potentially exposing them to serious side effects, treatment failure, and needless suffering. What are we asking for? Sufficient funding for countries to support the updating and implementation of pediatric tuberculosis policies. The implementation of the WHO-recommended decision algorithms that can help diagnose and treat more children with TB. And sustained investment by the diagnostic and pharmaceutical industry and donors to develop medical tools that can improve TB care in children. As you can see, pediatric tuberculosis is a complex systemic problem. A context-adapted approach is needed for each situation, and, above all, more attention and more funding commitments from the involved public health stakeholders.